Ladies and gents, welcome to another episode of Cup of Nurses, episode 108. We're going to talk about a great topic here. It's going to be perfect for nursing students, anybody that needs a refresher in some potential labs and things like that. But before that, we're going to have some wine here. We got Snoopy Dogg's wine.
Pop it open, dog. And remember, 4:30, we're going to launch something great for you guys. It's going to be some cool, mindful, and wellness material for everybody listening out there.
About consciousness.
It's going to be great. Hope you guys will enjoy it. We're going to start this whole new movement for, I don't want to say for who because I don't want to spoil it, but it's going to be for the greater public and for the greater good. A lot of stuff going on in this world, and a lot of times we forget to be present in the moment. We kind of forget to get in tune with us. We lose touch with ourselves, and we want to kind of ground everybody back into being who they want to be. And I want to encourage everybody to pursue their happinesses and their career goals and life goals. And we just want everybody to be well and happy.
Yeah. And before we start the show, thank you for listening. Those that are new, welcome. You guys are going to have a great time. Those that are coming back, always listening, thank you. Appreciate it, guys. We actually made it to the top 25 podcasts on rntbsn.com. So cool. That was awesome. That was a cool little achievement for this Friday morning that the time we're recording at.
Yeah, I'm not sure how that gets ranked, but we're on it. And we happen to be number one on the list. Initially we thought we're number one overall, but it was alphabetical order. But still, we're still number one up there. So it's actually pretty cool. I'm glad we named our podcast Cup of Nurses, because when we get listed in alphabetical order, like C is the third letter in the alphabet, so we're always going to be on top. And a lot of times people don't scroll to the bottom of the list. So
we're up there, bro.
People get recognition.
I think we're number one. If not, we're slowly coming there, man. So
for sure number one.
And I just wanted to say that we don't have any ads. We're not playing any ads. We're not slipping any advertisements in. So
actually, low key, we're slipping one in right now. Whoever's watching us on YouTube, we have our NCLEX study ad right in front of us. Since we're going to talk about labs, we decided to do a little shameless plug of the NCLEX study guide right there in front of us. If you guys don't know where to find it, hit us up. Just check out our website, cupofnurses.com. It's over there.
And last thing, if you guys like this podcast and find value in it, please give it a share. Share with your friends. That's how we grow, and that's how we get motivated to keep on producing high-quality content.
Yes, sir. So
what are we talking about, Pete?
So we're going to talk about the 9 most important lab values that every nurse should pay attention to every morning or afternoon, or depending on when you draw your labs.
Yep.
This is a good episode for all you student nurses out there, all you new grad nurses out there, and it's a nice refresher for all nurses in general. And if you're like a med surg nurse trying to step up and go to ICU, this is going to be very informative for you, because in the ICU every morning you get a list of labs, and we make sure everything's accounted for. We dot our I's, cross our T's. Every lab's got to be within a good what do you call
range?
Good range. Solid, dude. Range, mean, median, mode, and range.
Exactly.
It's got to be in a good range, because every electrolyte imbalance might make the patient a little bit worse, and then these little issues, they can stem into one big problem, especially with these top ones like potassium, magnesium, and these major electrolytes that we're going to go through.
Agreed. Have a sip of wine, bro.
I did. I got one.
Okay, great. Tastes good, right?
Yeah, I'll have another one.
So the reason why electrolytes are such an important and vital thing in the hospital and everything, like they literally manage homeostasis. Like they regulate the myocardium, neurological function, like fluid balance, oxygen delivery, like acid-base balance. Like the list keeps on going, and they're mostly important for all of our nerve cells and all of our muscle cells and heart cells, because you need electrolytes to maintain voltage across the cell membrane. That's what carries the electrical impulse to your nerve impulses, to your muscles, so they could contract. Like they're across every single cell. And fluid shift shit happens in the hospital, and there's always issues, and we're always trying to chase lights. Like it's such a major thing.
Right. And we don't only look at lights, we look at the whole CBC. So you want to know where your white blood cells are, where your red blood cells are, your hemoglobin. We also look at your liver enzymes, your kidney function. There's lots of stuff to pay attention to. And it's very convenient for us nowadays as nurses to have all this information presented to us every morning.
Yeah.
At one point, nurses didn't have these kind of values presented in this kind of manner, because every morning you have a list of labs for you guys that aren't nurses that you never looked at, like the results review section of a MAR, or not of a MAR, but of a patient chart. It's like a spreadsheet just with lab values. It's clutch.
Yeah. And usually nights draws them, days kind of looks at them, they troubleshoot them. We like replace usually in the morning around the clock. So I think the hospital has an interesting setting when it comes to lights. So let's start with the first one. We have potassium, which is a range in adults 3.5 to 5.2. Children 3.4 to 4.7 if you're in peds. Very important electrolyte. Everything has to do with the heart, especially having cardiac patients. We're always trying to have like a potassium above 4, right? It aids in nerve function and muscular contraction, and also helps like the heartbeat stay regular. And usually when you have like especially with the kidney patients, we always see like T waves sometimes, right? They're always going to PVCs, PACs.
Yeah, peak T waves and stuff like that. So yeah, so we use potassium to assess like acidosis. Someone's acidotic, their potassium is usually high, and then we need to push that potassium from the outside into the cell to lower the pH. It shows us AKI, CKD, dehydration, and if certain therapeutic interventions are actually working. So some of the signs and symptoms you might see with like hyperkalemia, which is a potassium over 5.2, muscle weakness, nausea, vomiting, heart palpitations, cardiac dysrhythmias, like people go into VTAC, VFib with these kind of issues. You're going to see peak T waves, PR prolongation, and even loosen P waves. You might have a missing P wave here and there. How we treat it, IV glucose and insulin, that, like I said, pushes the potassium back into the cell. And then we give the glucose. Insulin is the one that actually is pushing the potassium inside the cell. Yes. And we give glucose because if you're giving insulin, your sugars are going to drop. So we got to back that up because insulin is great to push potassium in the cell, but then it also fights off your blood sugars, right? So you got to counteract that with the glucose. Sodium bicarb, we're going to give diuretics, caxlate, and dialysis. Caxlate kind of sucks because it gives them diarrhea basically.
Poop so much.
Yeah, and I hate that because there was in Chicago there was one physician that always would give caxlate for high potassium, and I hated that because I knew if that was on call and it's a high potassium, he's not going to go any other route besides caxlate first, and that doesn't work.
You just didn't want to give any regular insulin, huh?
Yeah, but the thing is, caxlate takes some time to work, So if someone's like, has a potassium of like 6, or like 5.5, or like 5.8 in the high range, it's kind of scary. It's kind of nerve wracking because they're gonna. You don't know what's gonna happen. Like they might go VTAC in a scary situation.
Right, and usually in the hospital, you're just gonna treat the underlying cause. So if you have a high K and you don't want to mess with insulin and stuff, maybe you're just gonna do the dialysis and try to bring it down instead of like. There's no point of pushing insulin and what is it called? Giving D10 or D50 if the patient's going to just need dialysis or something. And also nursing considerations. Usually potassium comes in like 10 MEQs and 100 if you're giving it.
Yeah, we give. See, the thing in Chicago, we got 20 and 40 bags.
Yeah, and I was also going to say if you're doing the higher concentration, it has to be in a central line, which is usually just ICU.
Yeah. So for hypokalemia, it's potassium less than 3.5. Some of the things you might see in a hypokalemic patient is going to be mainly shallow respirations, confusion, decreased deep tendon reflexes. That's the one where you hit the little hammer on the elbow or on the knee. They're going to have loss of bowel function, and DKG strips, you might see a depressed ST wave, a flat or inverted T waves, and you're going to see that special U wave that's indicative of hypokalemia. Like Matt said, how we're going to treat it is IV potassium or PO if they can. You're going to hold the diuretics, and you're going to also hold DIG because if you're hypokalemic, you're at a higher risk for DIG toxicity.
Damn, dude, you probably got that from one of those questions to do for the travel contract, right?
I actually did.
Yeah, good reminder, bro. That's where I got that one from. Like, how'd you know that, man? I'm like, yes, this is how. Some considerations when you're giving Lasix, like stay on top of your potassium. That's one thing I hate is that like when potassium doesn't get checked at all. Sometimes it gets delayed, or you're pushing Lasix throughout the shift. No one thinks about checking a K or following up. Maybe, hey, let's get a BMP. Yeah. They check it at 3 a.m. Sometimes it's like 2 point something, 3.1, and we're always trying to play catch up instead of like staying on top of them.
Yeah, it's scary because like Matt said, people have ordered like IV push Lasix Q4 hours, Q6 hours, and then especially on night shift, I come on night shift and I see that, hey, this guy's been getting Lasix Q4 and they haven't checked their lights, since 8 o'clock in the morning or since I checked them last night, so there's no labs since 4 o'clock in the morning. And I'm just like, holy shit. I'm like, did you guys spot check them? No. I'm like, all right, well then that's probably the first thing I'm going to do is I'm going to throw some labs under a physician. I'm not even going to call him, just throw it under him, get the spot check, and then call him back like, hey, I threw a lab order under you. Yeah. Because if it's been 12 hours and 12 hours plus, if I do my labs early at 4 o'clock, it's been, more than 12 hours since you last checked his lights and you already got 3 doses of Lasix.
Right. Especially if you have a patient on tele, like you start seeing like there's like inconsistency in like heartbeat or throwing some PACs, PVCs, like, yeah, let's check the freaking lights, man. So just like do your due diligence, and like use your common sense or critical thinking to see what you want to do, right? Just like giving blood, right? A couple days ago, I gave blood, a unit of blood for hemoglobin of 8.8, correct? The reason why I'm giving blood is not necessarily for anemia. I'm giving it so you could get off pressors because he was a little bit low. Am I going to check a CBC in 1 hour, a couple hours, Q4? Probably not, because we're not giving it for anemia. Another patient, if it's like 5.9 and give a unit or two, you might want to follow up to see if it's above 7. So just, use, sometimes doctors don't put it in, but just think about those things critically. And that's like makes you sometimes a good nurse or a bad nurse. They'll separate you.
Yeah, sometimes you give blood just for volume. Albumin doesn't always do the trick. And if someone's, borderline low hemoglobin or borderline anemic, and he's hypotensive, maybe he just needs extra unit of blood. And that's what might, like you said, get him out the pressors.
Yeah, my patient was on dopamine, just low dose. That's going to help his cardiac output. So yes, I mean, that made all the difference, actually. Right. He went down from like 8 to 4 mics.
Yeah, there you go, business, step in the right direction. Electrolyte number 2 on here, or lab number 2, is going to be magnesium. Good range for magnesium is 1.8 to 2.5. Ideally, we like it in like the 2s. Magnesium plays a role in nerve function, transferring and storing energy, regulating the parathyroid hormone, which is also called PTH, and it plays a role in calcium levels. Your PTH plays a role in your phos and your calcium and your bone density and all that. For magnesemia is above 2.5, right? So what you're going to see is lethargy, hypotension, respiratory arrest, possibly diminished deep 10 reflexes. Once again, that's the one with the take a hammer, hit it on your elbow or hit it on the knee. We're supposed to respond appropriately. You can have prolonged PR and QT waves, and you can have a widened QRS. And treatment for this, IV calcium, diuretics, and dialysis. When you have high electrolytes, you got to get them out of your body, and the best way to get them out of your body is literally to pee them out. And IV calcium, it has an inverse relationship with mag, so that's why they give that.
Yep. And then hypomagnesemia is with a mag less than 1.8. Signs and symptoms could be hypertension. You might be irritable, hyperreflexia, involuntary movements. And those patients, when it gets low, you might have problems with your QRS. You could go into torsades, right?
Scary.
And usually treatment for that is you just give mag 2 grams, right? So that's, mag sulfate and mag oxide are the treatments for that.
Yeah, mag oxide is the PO1. Mag sulfate is the IV. I rarely give that mag oxide. Usually, I don't know, people are more prone to order magnesium IV than potassium. Potassium is kind of still is vasotoxic, but magnesium is a little bit too, but not as much as the potassium.
Yeah, not to mention sometimes you might be giving mag for diarrhea. So that's like after you're using your Colace and your Ducalax and your stool softeners aren't working, sometimes you're going to give magnesium citrate to get the bowel going. It's just your patient can have a bowel movement. Next one is sodium, 135 to 145. Sodium is probably the very, very important ones. We kind of like get worried about it and fearful because of like the American standard diet. We always talk about sodium, it's bad, but you could have overload of water and like diurese yourself, not diurese, fluid yourself. I had a patient that his sodium fell too low because he kept giving himself boluses through the G tube of water, and his sodium went under like 129. He became weak.
I think I call it hypervolemic hyponatremia.
Yes. Yeah. Just from doing that. So important electrolyte, even though we should be monitoring it when it comes to our diet. Nerve impulses, intracellular osmolarity, and promotes myocardial smooth and skeletal contractility. So important electrolyte. If you're above 145, which is hypernatremia, you might become restless, agitated, have some fluid retention because water follows sodium, edema, and decreased urine output. The way you treat it is usually give hypotonic solution. You run it slow because you could run the risk of having a brain, the fluids shift in the brain, correct? When it comes to the intracellular fluid.
You get a seizure, yeah.
Yeah. And then when it comes to, hypernatremia, like we don't have it often.
Not very often.
Yeah, not very often. And usually like if the patients are in the ICU, we have hypernatremia, we usually just give like fluid boluses. Free water flushes with the NG tube, like 300 Q4 shift or something like that usually.
Usually when somebody has severe dehydration, that's usually how they become hypernatremic.
Yeah, and it's usually easy to replace because, with COVID, we haven't been doing it as much because they want to keep them dry. But we just give a bolus sometimes, like 250, 500. Actually, no, you can't give 0.9 boluses, bro, because you would increase sodium. Yeah, because great catch. I almost gave bad advice on the podcast.
Isotonic or hypotonic solution.
Hypotonic, that's right.
So for a hyponatremia, exact opposite. It's a sodium less than 135. This is the scary one. This is the one you're going to see more often than hypernatremia is. If someone is hyponatremic, might have seizures, stupor, confusion, orthostatic hypotension, spasms, and cramping is another major one. But the seizure is the one that we really gotta watch out for. So the treatment for this, if they're having hypovolemic hyponatremia, you want to give IV sodium chloride. You want to restore the fluids properly. You can also give hypertonic solutions, but they don't do that very often, like 3% saline. They usually just give 0.9. And then if it's hypervolemic hyponatremia, that's the one that we talked about.
Yes.
No, we had to talk about hypo. We had a flip. We talked about hypovolemic
Hypernatremia. Yes,
this one is hypervolemic hyponatremia. What we're gonna do is restrict the fluid intake, give diuretics. You wanna have your kidneys excrete all the extra fluid just to help concentrate the urine, so it'll bump up your sodium. And then of course, last resort is always dialysis.
Yeah, and these patients, I feel the worst for them, especially if they're urine oriented, because not only are you restricting your fluids like maybe like 1,200 cc's a shift, but then sometimes they have salt tablets, dude. Their mouth is so dry. I always feel so bad for them.
Yeah, it's crazy how we say be careful for dehydration, but sometimes we have to dehydrate patients to get them into like equilibrium. We have to dehydrate them, and then once they're dehydrated, then we could rehydrate them back up, just incrementally, making sure that all electrolyte levels are appropriate. Because you gotta stabilize before we kind of do anything further, right?
Yeah, electrolytes are freaking key for everything, and also neuro patients, like your neurologist will also order like strict sodium, like 135 to 145. They're gonna want that range. Depends on like what's going on. So I think neuro uses sodium a lot. Even dialysis patients too. And like same thing, like back to my patient, the one that was had low sodium, he had hypotension as well. So it could have been just all related. I mean, he had pneumonia and TB, so that kind of like plays a extra part into it. But he could have been hypotensive as well from hyponatremia.
We'll see.
Yeah, learning on the podcast too, man. Calcium. So calcium range 8.6 to 10.3. It actually helps regulate cardiac, smooth muscle, skeletal muscle contractility, impulse transmission, and it actually automates the heart, the cardiac cells, and the contractility of it. If you have hypercalcemia, you have a calcium of 10.3. It causes muscle weakness, disorientation. You might have absent reflexes and potentially develop kidney stones. When it comes to the EKG, you might have like shortened QT intervals. When it comes to treatment, calcitonin, some fluid, some loop diuretics. You want to flush the extra calcium, IV biphosphates, and dialysis, of course.
Yeah. So with phosphorus and calcium, they're inversely proportioned. So one goes in, one comes out. So for hypokalemia, you're going to have a calcium of less than 8.6.
You said hypokalemia, bro. Hypocalcemia.
Oh, sorry.
Yeah, we're freaking slurring the words here, man.
Dude, that wine's hitting us hard, huh?
There's so many electrolytes.
Sorry, guys.
Damn, Snoop Dogg, this freaking wine's good.
It's good, man. It's legit right here, guys. Shameless plug over here. Dude, you guys should try his wine. I'm not a big wine person, but this is tasty. Not gonna lie. It's very smooth, very, very fruity. So for hypocalcemia, it's a calcium less than 8.6. Patient's gonna exhibit confusion, hyperactive reflexes, muscle spasms, I always butchered this word. Positive Trousseau's signs. That's the one where you blow pressure cuff and you wait 3 minutes, and if the arm contracts, it's positive. And then the other one that I always mess up, Chvostic sign, which is a contraction of facial muscles provoked by light tapping over the facial nerve anterior to the ear as it crosses the zygomatic arc. So I always butcher those words, but I don't do that very often. I do the one with blood pressure cuff more often than the Chvostic. But hypocalcemia, not that very prevalent.
Yeah,
I see. So we do have hypocalcemia in the hospital, but it seems to never get low enough for anybody to exhibit these signs, at least in our ICU. But it's majority cardiac, but it's whatever. So how would you treat it? IV calcium chloride or just calcium gluconate? I haven't had anybody has ever had serious adverse reaction from low calcium on a personal level.
Exactly. And plus in the ICU, we actually look at ionized calcium more often. And that's actually calcium that's free circulating in your blood that's not attached to protein. Supposedly, the studies are suggesting that using ionized calcium is more superior to identifying like distributions in patients that are receiving like blood products, and they're like in CKD and stuff like that. So in the ICU, sometimes we'll give calcium gluconate based on a ionized calcium level. And sometimes we get them just from the ABGs.
Yeah, I haven't done ionized calcium until LA. We do look at regular calcium back in my prior hospitals.
Always, yeah.
I'm not sure what they look at our hospital now. You know, if they look at ionized or regular. I think they just look at regular.
I actually haven't had a. I mean, it's only been our second day. By the way, guys, we were on day shift. We didn't even mention that day shift has been interesting. But I didn't even get to it because when I checked ionized calcium, it shows up on ABG. So it was normal for me. I never questioned it, but I wonder if they actually look at it.
On a regular, like the CBC and like the CMP that we draw and the liver enzymes, like it just says calcium on it. I didn't see the ionized for both days that I worked.
And they drew an ABG as well.
The ABG, I never really look at the calcium in the ABG, to be honest.
Okay.
So I can't really tell you. I mean, I haven't checked. My patient did have an ABG drawn, but I didn't look at the calcium.
Okay, interesting. So phosphorus level 2.8 to 4.5. Most times that I replace phosphorus is in critical settings and mostly on CRTs. Whenever we have patients on CRTs, all the electrolytes are getting replaced usually through the bags, except for phos. And usually we're replacing them. From my experience, they always put standing orders in for phos less than 1.9. So it works as a buffer for acid. It creates base balances, aids in muscle, neurological, and platelet function. So hyperphosphatemia, I don't know if I'm pronouncing that right. It's above 4.5. It might be causing confusion, hyperactive reflexes again, muscle spasms, and you're gonna have positive troci. I can't even pronounce those two, bro.
I know, man.
I'm gonna skip that, and I'm gonna skip it because even if I told you, when you're a real nurse, you're not gonna even do both of these signs. You're gonna just check a lab calcium and you're good to go. True. Or even lab calcium and lab phos, because these are both prevalent to those signs.
But what's on the NCLEX, dude? You should try and pronounce those two words.
Oh man, don't put me on the spot.
I got to, man. I tried to pronounce them. I butchered them. You're not gonna do any worse, dude.
Positive troceus and chivostex. I'm about to go on Google and fact check myself, but treatment. We're gonna get medication called Phoslo, which actually binds to phosphate, and it gets removed via stool or dialysis. Hypophosphatemia is less than 2.8. It could cause respiratory depression, rhabdo, osteomalacia, which is weakened bones, irritability, decreased platelet aggregation, and immune suppression. Treatment, usually we give some IV vitamin D or just regular vitamin D with this to replace that.
Yeah. I guess, yeah, like when I looked this up, I didn't know phosphorus plays this much roles in the body. Like I just thought it was inversely proportional to calcium. You know, phosphorus, you need phosphorus, calcium goes in the bones, and then vice versa. But it's pretty fucking crucial.
Yeah, sometimes you're just so busy that you have no time to do this extra research. But clearly, it has to do with respiratory depression. So it makes sense when we have patients on ventilators. We want this electrolyte to be replaced.
Right, exactly. Next, we're gonna go on to our liver enzymes, the ALT and AST. So ALT, I forgot what it stands for. I remembered it a couple hours ago when I was gonna say on the podcast, but I completely forgot what the fuck it stands for. But ALT, AST is what it shows up on your lab review. Normal ALT is anywhere from 29 to 33 units per liter for males, anywhere from 19 to 25 units per liter for females. Plays a big role in liver function. We use it as a liver function test, and it's used to evaluate the liver. The higher the concentration, the more liver damage there is. But the interesting thing about it, when I looked it up, it's actually found in the highest concentrations in the liver, but it's also found in the kidneys, the heart, the spleen, the pancreas, RBCs, and skeletal muscle. So it's actually pretty interesting because I always thought ALT-AST is just found in the liver. But it just shows you that why people have high ALT and high AST, it affects more parts of the body. When they have a very elevated ALT-AST for a long time, they usually go into organ failure. Not just liver, but they also go into kidney failure, and the heart failure goes on to that. You get into portal hypertension, and then now you realize why it's so important. And it makes sense because, it also affects RBCs, and if you have improper RBC formation, it's going to affect everything else in your body, right? So it's a very sensitive test. It's going to basically be our rationale to assess for liver disease and liver damage. That's simple. AST, like there's no low range for ALT. It's just gonna be elevated, unlike compared to like electrolytes. So for AST, same. It's another liver enzyme that we use to look at for liver function. Normal range is anywhere from 20 to 40 units per liter for males, anywhere from 15 to 30 units per liter for females. So AST is an enzyme catalyst that is part of the Krebs cycle, which helps make ATP. I didn't know that one either. So look at that. We're all learning here. An AST exists in.
So funny,
Yeah,
man.
right?
Sarcasm. Continue.
I'm being serious, dude. Like when I was doing research, I'm just like, goddamn,
It's a
one
great
thing.
refresher, man, because like
Yeah.
as a nurse, you see these numbers and that's all that means to you.
Mm-hmm.
They're good. You just keep on going with your shift, and
Right.
here you're actually understanding, and it's making you a better nurse.
Yeah, and then AST also exists in the most abundant amounts in the liver, but also is present in myocardial cells, in the skeleton, also kidneys, pancreas, brain, and also RBCs. And same with ALT, it's another indicator that we use for cellular damage in the liver, which if your AST is high, your ALT is usually high as well, and then you're probably gonna, if that's not treated, you're probably gonna go into liver failure at some point.
True that. Yeah. Fun fact: if you get total parental, if you're getting TPN, remember that it causes liver damage. So if you have your patient on TPN, make sure you're watching the ALT, AST. If it's getting elevated, we got to do something else, man. Get this guy walking, get this guy awake. Maybe do 2 feedings. But he's on TPN for a reason. So
yeah, TPN is great because we learned how to give nutrition to a person just through the vein.
Without the GI tract.
Yeah, without the GI tract. But like a lot of things, that's not the way we're programmed to live, right? So it's not sustainable for a very long time. And if you can't be on TPN for life because you're gonna die. It's not you can be on TPN for a year. It's not how it works. You can be on it for a few weeks, maybe a month. You can't be on there for very long because, like Matt said, it's gonna destroy your liver. And then if your liver doesn't work, guess what's the biggest filter in your one of the biggest filters in your body to filter that blood.
And I've mostly seen them in when I work like ortho for the GI cases. Whenever you do like the Whipple procedure, like you just get a friggin' ton of your colon removed or something. They start the patient on TPN instead, because they have to rest the bowel. And also in the ICU, if there's something going on, if they're paralyzed and they're like prone to whatever for X amount of days, they'll get them going on TPN. The next one is on creatinine. Regular range is 0.6 to 1.2. It is a byproduct that's produced as energy to contract. I'm sorry. It is needed to produce the energy to contract your muscles. It's also something that the kidney is normally filtering as a substance, and that's the indicator that we use. And if you have a high creatinine level, that's basically showing problems with the kidney function, and your glomerules, the cells that are producing the urine, are doing a poor job. Yeah. And
it's basically indicative of glomerulus damage. Fucking these words, dude.
We're having a hard
Doesn't help that we're fucking Polish either, man.
Oh, it sucks that we're foreign because we're, English is not our first language, and then we got to like learn how to pronounce these. Mm-hmm. That's one thing that I struggle with too at the hospital, man. Is like talking to these docs sometimes,
not trying to sound like a
big
fool.
ass words, and I'm just like, not trying to sound like a fool and being foreign. It's like, dude, it's English is my second language, and I got to use all this medical terminology. Big things with creatinine is you want to monitor it all the time when you're giving very sensitive meds, like let's just say vancomycin, right? It could cause a lot of damage to the body, right? Kidney function. So we're always doing vancotroughs on that. We always want to make sure that the vancotroughs aren't too critical, especially with high creatinine. Or if they're going down a CT scan, we want to make sure the creatinine is within range because the dye, contrast dye, especially if it's IV, could affect your kidneys.
Yeah, even electrolytes. Let's say someone has a potassium of like 3. Right, and you're thinking, usually when potassium is 3, usually 40 does the trick. But if their creatinine's like 1.9, 2, you're probably better off giving them 20 and then rechecking the lights because they're not going to be able to excrete the potassium as efficiently as someone with a regular creatinine level, right?
Exactly, and usually if patients that have like high creatinine levels, there's going to be a nephrologist on board, and some hospitals have potassium protocols. Sometimes these protocols will be removed when a patient is high creatinine, and the kidney doctor will manage everything. Just like I learned when I worked a couple of days ago, is I gave my patients I think I gave like 38 milliequivalents, and I'm like, doc, you want to give a little bit more Lasix maybe? Like his creatinine is decent. We got to diurese him because his CVP was 25. She's like, what? I'll just do 1 dose, and she'll just see how it goes.
Yeah, makes sense. Another thing that we look at with creatinine, we look at BUN, which measures the blood urine nitrogen in your blood. Normal range is between 7 and 21 milligrams per, I think, deciliter. DL, right? Deciliter?
Yes.
Seems legit. Basically, same with creatinine. It shows us the kidney function. If it's elevated, that's a concern because it can show kidney failure. It could show that patient is in shock, and it could also be indicative of heart failure. So yeah, those are 2 important ones to look at for kidney function. If it's elevated, something's going on with the kidneys. Are they in AKI? Have they been chronically elevated because of CKD? You know, it's something you got to figure out.
Yeah, sometimes a patient will be hypovolemic for X amount of days, or we intentionally do it maybe by accident. Yeah, BUN creatinine is going to go up. You know, same thing if you're pushing Lasix. You got to be careful because Lasix works. You're over diuresing. Hey, your creatinine is going to start climbing up. Or when they're on a Bumex strip, right?
Yeah, because it puts a higher workload on your kidneys, and sometimes our kidneys aren't healthy enough to, you know, take on all that Lasix and diurese that much, you know, urine with that amount of time. Yeah.
Freaking electrolytes, man. It's just beautiful thinking about this and how like intricate the body is. You know, like you're literally a electrical conductive system in the human body. You're trying to maintain voltages. You're maintaining fluid shifting, fluid volume, acid, base on ABGs with all these electrolytes. And now we're gonna get into anticoagulants, which is coagulations when it comes to PEs or when it comes to, you know,
Coumadin,
warfarin, like Lovenox, like that's a whole nother thing. You know, you got AFib now. You want their INR to be elevated. You could be, you know, be potential for high risk of, you know, like, you know, having what's the other one? Coumadin. I'm trying to what's the other one that Eliquis. Yeah, I haven't seen it often because of, you know, we have all these COVID patients. You got to be careful. You fall, you might be, you know, bleeding out, and that's like the saddest thing with when it comes to anticoagulations is like, you have these patients that always fall in nursing homes and something like that, and they come into the ICU and they have brain bleeds. Yeah. We can't do anything about it, and usually it's because of just anticoagulants. And it's like, a sad truth, man.
Yeah, you gotta find like a fine balance because you don't want on too much anticoagulation because then they're at a super high risk for bleed. But then again, if you don't put them on anticoagulation, they're at a very high risk for getting a clot. You know, so you got as a doctor or a physician or anybody out there that, you know, prescribes this, you're playing a vital role between, is a patient at higher risk for a fall or an injury that's going to cause a bleed and they're going to die that way, or are they higher risk for throwing a clot or a PE or anything like that, or, you know, a stroke? It's crazy, man.
I mean, the benefits outweigh the risks when you're outside of the hospital, but when you're in, like, you can't operate. Sometimes the surgery gets delayed because it takes like 5 days before Eliquis, like, you know, technically leaves the system. It just creates a lot of issues, you know, when it comes to anticoagulants. Regular range for PT is anywhere from 10 to 12 seconds. Where this is regarding clotting factor. And then we have INR, which is a regular range 0.9 to 1.1. And then there's also PTT, which is another great one. So, and there's also another one like anti-XA. So it depends on what hospital you're at. Sometimes when let's just say you're managing a heparin drip, you're going to do PTT. But sometimes in other hospitals, they do anti-XA, which is just another like a lab value they check when it comes to the clotting cascade, right? That they check. And supposedly that one is more accurate instead of the PTT.
Yeah, so it's cool because I actually looked into the PT and INR, and this actually assesses the extrinsic and common pathways. So basically, this allows you to see how fast a prothrombin gets turned into the thrombin, right? So extrinsic pathway, that's a clot formation that is activated when there is external injury resulting in blood loss. Intrinsic is clot formation is activated when there is internal injury. So it's interesting how one mechanism gets activated if there's damage coming from the outside that's causing bleeding, and different mechanism gets activated when there's internal bleeding going on. And then the common pathway is where the intrinsic and extrinsic pathways meet to form the actual clot. And these, in simple terms, these lab values tell you how quickly your blood is going to clot. Obviously, the higher number, the longer it takes for your body to clot, the more bleeding risk you have, in layman's terms.
In layman's terms, yeah. And also, I wanted to say something about heparin still. And like sometimes we give you these lab ranges, but there's going to be different goals that are going to be set in place. For example, you have a patient on a heparin drip, and the goal range will be 60 to 90 instead of like, let's just say 21 to 25. So everything just changes in the hospital, gets a little bit different.
Yeah, and plus there's protocols. There's like there's different strengths of it. I can't forget top of my head, but the heparin dosages. There's like the low dose, the moderate dose, and the high dose, and there's the cardiac dose. So that depends on protocols. Where the only difference between protocols is the therapeutic PTT range. Obviously, the more intensity there is, the higher the PTT is going to be. So more room for clotting, or less room for clotting, more room for bleeding.
And these are like top 9 maybe that we kind of like picked out that are very important. And like the list could go on. We could list so much things like ABGYs. Lactics are another one that we check when it comes to, sepsis. Like you have procalcitonin, which now people, doctors and physicians, they kind of geared away from lactic acid as much, checking for sepsis. Now they check procalcitonin. Like there's just so many other lab values that are interesting.
Yeah. These are like the 9 basic ones that everybody should know, I feel like, for every unit.
Yeah.
Standard.
For example, like, the ACH, when they check the cortisol levels in the morning, like my patient had TB and they're like, oh, like he's hypotensive. I wonder where like the TB is. Like, let's check the ACH level in the morning. Maybe he has TB, tuberculosis in his like adrenal glands. I'm like, what? Like,
right?
Yeah, there's just like, this is why another thing I love days is just like the knowledge you're talking. You're just like talking to physicians. It's just like, there's a bunch of residents too, by the way. So they're like, he's teaching them things. You just have to like listen and you like learn a lot.
Mm-hmm. Yeah, it's cool because there was some teaching going on. There was a resident, or I don't know who it was, but there were 3 people there. I'm not sure who was a resident and who was who, but they were all like bouncing these off each other. And I was trying to listen, but then I was like, I had families to deal with, and I was just catching like small parts of the conversation. They're like comparing ideas, and it was cool to see that.
Yeah,
I'm not sure who was right and who was wrong, but
yeah, I was talking to one of the ICU physicians, and he was upset because like there's no protocols in his hospital that we work at. So it's super annoying because if potassium is 3.4, like I don't gotta call the doctor for something so damn silly. I know I need like 20 milliequivalents just to replace it, and they don't do that here. So you just have to call for him, and he just gets annoyed by it.
some have PRNs though. They don't have like my patient had PRN, potassium and magnesium, and I would just replace it according to the parameters.
No way.
It's not an actual protocol, just a physician orders a PRN. I guess not everybody orders it, but I know in Chicago we had protocols for lights. Everyone would order them. We never call for lights because they'd always be covered, unless they had like you said, unless they were on dialysis and had a high creatinine.
Yeah, and this is where it comes with like travel nursing, the policies and procedures. Because I used Cerner where there was protocols, but they didn't like there was care sets that they activated in Cerner. So see, there's just different. There's different versions of these medical systems, these EMRs, and they just modify based on like how the hospital does it.
Yeah.
Same thing with like here, like they wedge, for the swans.
That's cool. That's cool.
The reason why I'm still chatting is we're only 35 minutes in, bro.
That's okay. It's 35 minutes of knowledge, dude.
Yeah, this was a very jam-packed episode, like just full of like learning. So hopefully you guys enjoyed this one and had some value wherever you're driving, wherever you're listening, or maybe mowing the lawn, working out, whatever keeps you guys hustling, man. Thank you guys for listening.
Yep. So you guys take care. See you next week.
Peace.
Bye-bye.